Thanks everyone for joining. We'll just take one more moment to allow others to enter the room and then we'll get started.
All right, it looks like everybody from the waiting room is in.
Great. Okay, well, good morning and good afternoon, everyone. So pleased to have all of you with us today for this month's webinar of the Award Network. As you know, the Award Network, Advancing Workforce Analysis and Research for Dementia, is a new research network that aims to advance research on the healthcare workforce that supports people living with dementia. And this new network is supported by the National Institute on Aging. I am Kezia Scales. I'm the Vice President of Research and Evaluation for PHI, and I'm really happy to be one of the co-leads of the network. The other network leadership is on the call today as well, and I invite them to go ahead and introduce themselves in the chat. I also invite all of you to introduce yourselves in the chat so that we know who's in the conversation today. So please feel free to go ahead and put your name, your affiliation, and if you would like to share with us one of your New Year's resolutions, since this is the first time that we are meeting together in 2023. So what is one of your aims or goals for the year ahead? Before we get into today's webinar, I do want to let you know that the Award Network website is now live, which is very exciting. So we invite you to visit the website. It's at awardnetwork.ucsf.edu. And we are going to continue to populate the content of the website, but we have the framework there. And it will be a really important vehicle for moving this work along over the next few years. So this month's webinar is designed as a speed sharing session. We have 7 fabulous presenters who will be here to share a snippet of what they've been working on. The idea is that this gives us a chance to see a spectrum of work that's happening in our field, also for researchers to be able to connect with one another, to maybe potentially identify new data sets or potential research areas, or even research collaborators. So it should be a really exciting and fast-paced event today. Each of the presenters will have 5 minutes to share their work, and then we'll have 1 to 2 minutes for brief question and answer before we transition to the next speaker. Whatever time we have at the end, we'll be able to have further Q&A and discussion. But all along the way, all of us in attendance today can post questions and reactions in the chat, and there'll be opportunities to keep the conversation going in the chat as well. So I think we're ready to move on to the first speaker, who is Julia Bergdorf from VNS Health. Julia, would you like to take it away?
There we go. Sorry about that. Can everybody see my slides? Okay,
Yeah.
great. I have a timer going for myself. It's going to be closer to 6 minutes than 5, but I am excited to share with you all today. I'll be talking about supporting dementia caregivers in the home health setting. And just as a quick introduction, I'm a health services researcher by background, and my work focuses on the intersection of home-based care and family caregiving for older adults. I'm currently a research scientist at the Center for Home Care Policy and Research at VNS Health and a faculty associate at the Johns Hopkins School of Public Health. So I'll start with some quick definitions and kind of explaining why the focus on home health. When I say home health, I'm talking about the Medicare skilled home health benefit that delivers nursing, therapy, and aid services through visits to the patient's home. And about 1/3 of home health patients have a dementia diagnosis. So it's a major subpopulation in this setting. When I use the term family caregiver, I'm talking about caregivers who are regularly helping an older adult, largely based on their personal relationship with that individual. And so a couple of years ago, I wanted to understand the role that these family caregivers played in home health. And as a first step, we found that in 87% of home health episodes, clinicians reported a need for family caregiver assistance in order to implement the plan of care. This is both due to significant social and medical needs of home health patients, as well as the fact that home health staff can only be present intermittently in the patient's home. But a lot of these caregivers aren't necessarily prepared to take on this role. So here we have the proportion of caregivers helping during home health who have clinician-identified needs for training in order to safely provide that help. And as you can see in pink, over a third of caregivers need additional training or support. Focusing specifically on caregivers of persons with dementia in home health, unsurprisingly, we see that these caregivers are significantly more likely to need training in 6 out of 7 caregiving activities. Unfortunately, they don't often receive the training that they need. So here in blue, you see the percentage of dementia caregivers who need training with a given activity who have an unmet need for training. So across activities, about half of dementia caregivers who need training don't get it. This is particularly concerning given that our prior work has linked unmet caregiver needs during home health to worse patient outcomes, including twice the risk of hospitalization, lower patient and family satisfaction, and higher care delivery costs. So our next step was to try and understand why we see this problem and what the gaps are. We embarked on qualitative work first with home health clinicians. And the first big takeaway was that clinicians are interested in supporting caregivers and they see the importance of caregivers in home health. So the quote at the top, one PT told us, quote, "Having the caregiver is almost like having myself there when I'm not there. The caregiver can be like my backup." But clinicians also said they faced a number of barriers to supporting and training caregivers. On the top left, most salient was poor communication between clinicians and caregivers. But they also mentioned gaps in data systems, a lack of tailored interventions for the home health setting, and a reimbursement system that disincentivizes time spent interacting with caregivers. Our next step was to talk to the caregivers themselves, and we specifically spoke with dementia caregivers who've recently assisted during home health. They told us that there was a lot of information discontinuity within the home health care team. So they would tell the nurse something, the next week the PT would come in and they'd have to repeat themselves all over again. They also said that home health staff really never asked about their capacity or needs, and that when they weren't directly asked, they really didn't feel comfortable proactively bringing up what they needed. And part of this was because they didn't realize that there could be any support for them. So one caregiver told us, quote, "If I knew that I could ask for help, I would have, but I didn't think that that was something that I could do." So what we're trying to do now is put all of this together and solve the problem. So that should be very quick, very easy. We've identified 4 key components for improvement here. Again, all going towards improving that support for dementia caregivers in home health to then improve quality and outcomes. Starting on the left, the home health care team needs to proactively ask caregivers about their capacity and needs, then to present them with options for support and hear their priorities. Also to solicit information about the patient. Caregivers are really able to fill in a lot of those information gaps for home health staff. And finally, to store and share all of this information within the care team. This is my last slide. In interest of time, I won't go through all the moving parts, but this is a model we've created for successful communication and support of dementia caregivers during home health. And the idea here and why I think it really is a good fit for kind of a workforce lens is that we have dementia caregivers and the home health care team as partners during home health in providing care, especially for those with dementia. Each actor has access to information and resources that the other needs. And what we want to do is create a process and intervention to facilitate that communication and collaboration. So I thank you for the opportunity to speed talk at you and share all of that. I know we have some time now, but this is my email. Please reach out with any questions or comments. Thanks.
Thank you so much for a fascinating presentation and so well modeled in terms of keeping to time. I think we could take one question before we move to the next speaker if anyone is would like to come off mute and ask a question. Otherwise, you can hold on. Oh, Joanne has a question, please.
Yeah, I just wanted to flag for you. I don't see him on here, but Kenneth Lamb at UCSF. And I just had a really interesting conversation yesterday also with Jarman Ye and Lauren Hunt about, he's a geriatrician and he is interested in exactly these kinds of issues about, as well as he was really interested in talking about transitions from being cared for at home or being at home into the precipitating factors of kind of, it's time for you to move into a place where you can get more support than your family can provide, and the complexity of that from a geriatrician and clinician standpoint about how to engage in those conversations and just the difficulty of all of that. So he might be a fun person for you to talk with.
Definitely. Yeah, I will email you after this because I know the name, but haven't met him. Yeah, and some of the issues you're raising, especially about the time to institutionalize, is something that came up a lot in our qualitative work.
Great. Thank you very much. Well, we'll move along to our next speaker. I am pleased to introduce Hayoung Arian Jung, who is from Weill Cornell Medicine. Arian, thank you for being here.
Can you see you guys my screen? All right. Okay. Yeah, so hi, everyone. Thank you for the opportunity to introduce myself and my work. I'm an associate professor in Weill Cornell's Department of Population Health Science. And most of my research is concentrated on examining the organization of the clinical workforce in nursing homes and the quality of care provided to these facilities. So for example, I have multiple projects that are underway to examine whether physicians and advanced practitioners who are primarily practice in nursing homes, often referred to as a SNFist, provide a higher quality of care to residents than other clinicians. I'm very excited to share some of the results from our studies. So I will start by talking a little bit about a SNFist. So these are clinicians who practice almost exclusively in nursing homes and are generally defined based on the volume of services provided in this facility, similar to a hospitalist. So there isn't a formal medical specialization in nursing home medicine, but the term SNFist has been used by CMS. So for my research, I use mostly conduct claims-based analysis. For example, I use Medicare claims extensively, especially the carrier and outpatient files, and as well as minimum data sets. I also use NPI level provider files such as MDPass and CMS NPI files called NPPS files, and so on. And I'm happy to discuss this data set more if anyone is interested in about these data sets. So next, I would like to share some results from our studies. So this graph shows the % of nursing homes using SNFists between 2013 and 2018. So you can see there was a rapid increase over this period. Only about 14% had adopted SNFist as of 2012, but this increased to more than 50% as of 2018. So next, I'll briefly show some results from an event study analysis we conducted to examine nursing homes' use of SNFist and facilities' 30-day rehospitalization rates for post-acute care patients. So our adjusted estimate indicated that use of SNFist is associated with more than 5% reduction in nursing home readmission rates. But the reduction wasn't seen until 5 years after SNFist adoption, according to our event study. So we also conducted a study examining whether the use of the SNFist is associated with better outcomes for long-stay nursing home residents with dementia. So the results of the analysis suggested that residents who received care from SNFist were less likely to experience potentially preventable hospitalization and ED visits, and less likely to report severe pain, and less likely to receive antipsychotic medications compared to residents who received care from non-SNFist. So lastly, I will mention a couple of ongoing studies. We have one study comparing the performance of physician synthetists and synthetists ward nurse practitioners. And the other study examines the performance of nursing home clinicians employed by the physician management companies. Thank you again for this opportunity. I'm happy to take any questions.
Thank you so much for your presentation. Are there any questions, comments, reactions from the crowd? Definitely seeing very interesting work here and appreciation for your presentation. Bianca, please go ahead.
Yeah, really interesting work. Never really heard of the term SNFist, so it's great to kind of be introduced to that. Is there a greater movement that you see towards training more SNFists? Kind of what's the state of kind of the future of SNFists?
I think right now, definitely increasing trends of using SNFists, but still there's a lot of work need to be done. First of all, the definition of SNF is the volume based. So it's not based on competency or their experience or training. So MDA, there's a definitely the movement of like what qualifies for the SNFist to define the SNFist model, but not so much is done in, I think it's very kind of like an early stage of the studies on SNFist.
Great, thank you.
Okay, well, you all can hold questions and comments as well as we move forward. But now I'm very happy to introduce our third speaker, who is Ella Mahmoudi from the University of Michigan. Thank you so much for being here. Please go ahead.
Thank you so much for having me. And hi, Joanne. It's so good to see you. Thank you again we had a lovely lunch. Joanne took me out when I was at UCSF as a visiting scholar. So thank you for that. And thank you for having me. I don't have any PowerPoint presentation. So if you don't mind, I'm just going to use the time that I have to talk about my research and the future direction that I'm heading toward. So I'm a health economist, associate professor of health economics at University of Michigan. I'm relatively new to Alzheimer's disease and related dementia. I got my K award about 2 years ago, and that's when I basically changed direction. As a health economist, and my K award was about predicting this model of 30-day hospital readmission among patients with Alzheimer's disease and related dementia. And what we found out was basically just the general stuff that we knew. We used electronic medical records from University of Michigan to conduct this study. While I was doing this study, I was also got funded through this NIDLR, which is basically fund research related to people with disabilities. And through that, my experience also was mostly to use administrative claims data. We did compare Medicare fee-for-service with Medicare Advantage for people with disability, physical disabilities, such as people with a spinal cord injury, adults with cerebral palsy, or multiple sclerosis. And it was fascinating for me when we compared adults 65 and older with Medicare versus Medicare managed care, that the rate of adverse health events such as emergency department visit, potentially preventable hospitalization, 30-day readmission was much lower even after complete matching of these patients who had two different insurance types. And that kind of motivated me to do the same type of analysis among people who have complex care needs, such as people with Alzheimer's disease or related dementia. So that's what I'm doing right now. This excited me as an economist to look at why there is this variations in adverse health events among this patient population based on their insurance. For those of you who are not familiar, Medicare Advantage is basically a capitated payment system run by private insurance, and they put more emphasis on care coordination versus Medicare for service or traditional Medicare is just fee for service. They provide the service and they get compensated for the service that they provided. And I've done prior studies among patients with diabetes, finding that they put more emphasis on preventative care. By them, I mean Medicare Advantage system, and racial ethnic disparities were lower in the use of preventative services. So again, using all that experience, I'm conducting the research comparing the two health insurance system for people with dementia. What we found out from our pilot data or preliminary results is mixed. And that's what I think makes the study more interesting. First of all, the background that people who are in Medicare Advantage are healthier than people in traditional Medicare, we found it to be true among our patient cohort of people with dementia. You would see that frailty index is much lower. They have low rates of chronic conditions. And these are all people who had the diagnosis of ADRD, if you will, in Medicare managed care. When we adjusted for certain explanatory variable that we normally use in our analysis, we found that in Medicare Advantage, the odds of having preventative services are higher. However, after adjustment, we didn't find much difference between the two insurance methods for adverse health events, such as potentially preventable hospitalization or 30-day readmission, or even not much regarding racial ethnic disparities in the risk for adverse health events. So this is an exciting project. It's and through literature, I also found mixed results. Again, I'm moving toward using to make it nationally representative Medicare claims data and encounter data, which has been recently become available to researchers for Medicare managed care, and continue this study. And I'll be more than welcome to whomever is interested in this line of research to collaborate. Thank you. That's all from me.
Thank you. Wonderful, wonderful, very interesting. Susan, I'm actually going to take the privilege of the moderator and move us to our next speaker. I'm really sorry. I just want to make absolutely sure that we have enough time for all of our speakers.
I'll put it in the chat. That's fine.
Perfect. And if we have time at the end, we'll definitely circle back as well. But now I'd like to move us along to our next speaker, who is Stephen McCall from Altarum. Thanks, Stephen. Welcome.
Thanks, Kezia, and thanks for the opportunity to share. And also, I am just so enjoying hearing from all of you about the research that you're engaged in. Elham, I'm glad that you went before me because I also don't have a PowerPoint slide deck, so I'll just be sort of speaking informally about a research project that I'm really excited about, that I started in my previous role at PHI with Kezia and with Laura. So huge shout out to the UCSF Healthcare Workforce Research Center on long-term care for supporting this work. But basically, this research was really motivated by this recognition that direct care workers, so personal care aides, home health aides, and nursing assistants, have a really central role in supporting the health and well-being of long-term care consumers, including people living with Alzheimer's and other related dementias. But direct care workers often face barriers to accessing healthcare themselves. There are a number of factors that sort of shape this understanding, including the socioeconomic characteristics of this workforce. They're often low-income women, people of color, and immigrants. They're facing occupational hazards in the field. For example, the sort of lifting and transferring of consumers is strenuous work. And they have limited financial resources, both in terms of their income, but also health insurance, as descriptive analyses and other studies have shown in the past. But what we wanted to do with this study is really dive more deeply into the experiences and characteristics of these workers. So using pooled National Health Interview Survey data from 2014 to 2018, we studied direct care workers' health status, their health insurance coverage, and their healthcare use, which we define as healthcare access, utilization, and affordability. I want to acknowledge, too, that this study is really building on previous findings from Dr. Maddie Sterling and her colleagues, as well as Dr. Sharon Silver and her colleagues. So while this research isn't publicly available yet, there is some literature that I can share in case you're interested. I'm not going to describe their research in detail, but I'm happy to share those links. So in terms of the variables we were looking at for direct care workers, we were looking at for health status, their self-reported health, disease prevalence, health indicators like missing work frequently, and health behaviors like smoking, drinking, and physical activity. For health insurance, we looked at their general insurance status, the source of their insurance, their coverage consistency in the previous year. And then for use, again, we looked at access, utilization, and affordability. And we basically included as many meaningful variables as we could in these areas to paint a really holistic picture of these workers' experiences. To sort of contextualize these findings, we compared direct care workers against all other healthcare workers first, using descriptive statistics. And then explored differences within the direct care workforce, including among home care workers, nursing residential care aides, and hospital aides. And then for the key indicators or outcomes of health service use, we used multivariable logistic regression. So those three indicators were having a usual place for care to assess access, seeing or talking to a doctor in the previous year to measure utilization, and skipping or delaying medical care due to cost to measure affordability. And for these regression analyses, we're really focusing specifically on the direct care workforce and controlling for a range of socioeconomic characteristics, including coverage consistency in the previous year. And what we found, not surprisingly, was that direct care workers do face more significant health issues than other healthcare workers. They had worse self-reported health, worse health behaviors, and higher rates of chronic conditions. Also, home care workers and nursing and residential care aides specifically were more likely to have a disability and to smoke than hospital aides. But really importantly, we found that a quarter of direct care workers experienced a gap in their health insurance coverage or didn't have any coverage during the previous year. And for home care workers and nursing and residential care aides specifically, they had much more limited access to insurance than hospital aides and other healthcare workers. So in this regard, hospital aides who are doing similar work to other direct care workers actually had better access to insurance than other direct care workers. And a big driver to these disparities in coverage was more limited access to employer-sponsored insurance. Employer-sponsored insurance was much more rarely offered in home care and the nursing and residential care industries. As a result of these shortfalls and other concerns, the direct care workers experienced significant challenges accessing, utilizing, and affording healthcare. And we found through our regression analysis that the single biggest contributor to disparities in access, utilization, and affordability was insurance coverage, right? The odds ratios for insurance coverage were really just astoundingly large or negative, depending on the indicator. There are a couple of important caveats with this research. First, because of a change in the survey design in 2019, these data are a little bit dated. There are now more recent data available with occupation and industry codes, and those new data have COVID variables, which we were not able to include. So that's something I'd love to explore in the future, or I encourage someone on this call to do that research. And the other issue was we were using less precise occupation and industry codes. This issue has since largely been resolved in the NHIS, but for the period we were looking at, we necessarily included some non-direct care workers like childcare workers. And through an analysis crosswalking industry and occupation codes, we found that non-DCWs constituted about a fifth of our DCW samples. So a little bit of a limitation there. But overall, I think these findings really underline the need for better insurance coverage for these workers, and also a range of policy and practice interventions so we can keep these workers healthy and in turn ensure access for older adults, people with disabilities, and people living with Alzheimer's and other dementias.
I think we lost Kezia.
Oh, we did. Okay. I can try to step in here. Thank you so much, Stephen, for your presentation. And I think we're going to continue to move on. And as there are a couple of questions there in the chat, so please feel free to respond there. Next up, we're going to have Jenny Rectory from Icahn School of Medicine at Mount Sinai. So please go ahead when you're ready.
Sorry, thank you. I do have slides. Can you guys see them?
Yeah,
here?
Okay, good.
Great. All right. So thank you for the chance to present. I'm Jenny Rectory. I'm a geriatrician at the Icahn School of Medicine at Mount Sinai, and I'm going to be talking about paid caregivers and the home-based dementia care team. So this is work that I've done as part of a NIA-funded career development award. And so, paid caregivers in the home, I define it very broadly: home health aides, personal care attendants, other direct care workers. They really provide essential long-term care to people with advancing dementia who are living at home, but we don't know that much about what it really looks like day to day. How is their role in care determined? How do these roles change over time? And so what this project was is a really, really deep dive into what's happening. So I did triadic, longitudinal, semi-structured interviews. And how we set this up is that we identified people with moderate to severe dementia, identified by their geriatricians, and approached their primary family caregiver, a primary paid caregiver, and a geriatrician to have an interview. We did the initial interviews and then follow-ups at 3 and 6 months and used framework method of data analysis. So all the interviews are done, we've been analyzing, and I'm trying to put it all together. So feedback and insight would be appreciated. But just to go quickly, so in the end, we have 9 triads. So the people with dementia who are represented really have a lot of care needs. 5 of 9 had 24-hour care, 6 of 9 had Medicaid. And this translates to 29 unique respondents and 75 interviews, so lots of data. Just a little information: the family caregivers, mostly daughters who didn't live with the person with dementia. Most paid caregivers were born outside of the US, wide range, like 4 months to 20 years working as a paid caregiver. The geriatricians too, between like 4 and 30 years of work as an attending physician. So I'm going to present kind of 3 groupings of results. The first group of results is really at the level of the triad. And so the idea here was to think of those 9 groups and sort of pull in, what the family caregiver, what the paid caregiver, what the geriatrician said, and then using their words, try to characterize kind of what was going on in this triad, both in terms of the overall home care situation and then the paid caregiver role. So the first one's just an example. So this was characterized by the son, the paid caregiver and I are doing the best we can. So in this group, the patient very much did not have enough care. He was alone at night, very unsafe. His son couldn't stay with him and couldn't afford more care. And so in this situation, the paid caregiver role was interesting. The paid caregiver role, she was very involved in the day-to-day care, very focused on the safety, but there were these very clear professional boundaries, largely, I think, because there was so much that was outside of her control. And you can just see there's a lot of detail here, but different things, very, very different dynamics going on in each of these triads. We also have results sort of at the level of the respondent, and really the main finding kind of across all respondents, so considering geriatrician, family caregiver, paid caregiver perspectives, was that it's really the family caregivers who were driving that overall paid care role in the home. The paid caregivers and the geriatricians kind of deferred to the families to set things up. And the formal care plans offered really limited day-to-day guidance. They set the big picture, but nobody talked about looking at these plans to figure out how things actually happened. One thing was true is that, you know, within the home, many of these people had multiple paid caregivers, and they did approach things differently. Sometimes there was this primary aide who was sort of more in charge, and the ways things kind of went in a day-to-day way depended on the strengths and weaknesses of the various caregivers. But again, big picture, families set the care. There were differences amongst responding groups. So we did look, you know, did paid caregivers say different things than family caregivers, say different things than geriatricians? And that happened a bit, though not that much. One that I think is worth mentioning is that it was the paid caregivers themselves who really talked about, as thinking about their role, about this emotional connection, about their investment with patients. And families, even if they had really great relationships with the paid caregivers and said, you know, they're the best people in the world, they didn't necessarily talk about this part of their role, and the geriatricians didn't talk about it much at all. And finally, there's results of things that weren't said, right? So the reason I kind of set up the study this way is I wanted to see what changed over time. And the bottom line is that, I mean, a lot changed. 3 people died over the course of the 6-month period. People were in the hospital, caregivers changed, but kind of the big picture way the paid caregiver engaged didn't change. And so, yeah, it didn't change that much. The families were really setting the tone. Funding source, so Medicaid, non-Medicaid, again, mattered in some degree, but didn't change that much what the role was. Some of the most involved aides who were taking on the most role were funded through Medicaid. And agencies, there was also a private pay through an agency. The agency involvement was pretty minimal. And finally, geriatricians really got involved when there were problems. So the geriatricians could not tell me much about the home care situation until there were issues. And when there were issues, the geriatrician was sort of right there in the weeds. So putting it all together, which is the part I'm trying to do right now, but I think kind of big picture, I think what this really is saying is that it's family-centered home care is what we need for people with advancing dementia. And this is a common idea in pediatrics. But I think for these patients, obviously their needs matter. The functional needs of the individuals with dementia is what got that paid caregiver in the door. But it was really the family circumstances. So competing concerns, expectation, preferences, those were really driving that paid caregiver role. And the evidence for this is both, you know, obviously like from the text saying we defer to the family, but I think also there was much more difference between the triads than within the triads. Each triad was very nuanced and different, but everybody was more or less on the same page within the triad. And so finally, I think the implication of this really is that prescriptive standards for home care are not going to match these nuanced needs. And I think sort of shifting that conversation to talk about communication, expectation setting, goal-aligned care, I think that this is a better way to approach it when we're trying to care for people with advancing dementia at home. So again, like I say, trying to get it all together, any thoughts or feedback now or later would be great. Thank you, guys.
Great. Thank you so much, Jenny. And I'm really sorry that I wasn't on the call to introduce you at the beginning of your presentation, but I'm back on now, and I'm going to move us forward to introduce our
Uh-oh, she might be losing her hotspot
speaker
there.
of the day, who is Shirin Villani from the University of Toronto. Welcome, Shirin. Oh no.
We can see your slides, Shirin. So if you can just unmute yourself. Can you unmute yourself, Shirin? Oh, no. Uh-oh. Can someone else unmute her? Kat?
It's Kat, yeah.
Okay, we just have, hopefully we'll get this resolved. I'm wondering in the meantime, maybe we could have Betsy go ahead instead of sharing if we want to maybe try to troubleshoot that in the background. So Betsy, do you mind jumping in here?
Sure. I was
Betsy
just unmute myself, so if I can try.
Oh, great. Okay. All right. Let's try sharing again. Sorry about that.
I'm so sorry.
No, it's okay. We still have a little time here. So you're all doing wonderful in terms of timing.
Okay. I think I got it. Perfect.
Great. We can see
Now
your
you guys
slides.
can see my slides. Perfect.
Yes.
Okay.
Thank you.
Yeah, 3 years of pandemic has not prepared me enough. Anyways, hello everybody. My name is Shireen Dalani. I'm a nurse practitioner by training with experience working in a variety of specialized geriatric services. Currently, I'm doing my postdoc fellowship at McMaster University here in Canada. And I'll be talking about my PhD project called Voice Your Values, a tailored advanced care planning intervention in persons living with early dementia. I'm sure you all know there's an increasing acceptance of life-limiting nature of dementia amongst clinicians. However, integration of a positive approach in dementia care throughout the course of the disease is not a standard of practice. Older adults living with advanced dementia often experience acute care admissions, including to critical care in the last month of their life, and receive poor end-of-life care. These life-sustaining treatments did not appear to have a positive impact on the person's quality of life and reversal of mortality. Most individuals with dementia are not even offered timely advanced care planning conversations due to a variety of barriers associated with clinicians, patients with dementia, as well as their care partners. For example, many believe that when the person is diagnosed with dementia, they lose their capacity to engage in such conversations. To debunk some of the barriers and myths, I proposed Voice Your Values, a tailored advanced care planning intervention. And the purpose of this study was to determine the feasibility, acceptability, and preliminary efficacy of the Voice Your Values intervention in community dwelling older adults living with early stage dementia and their trusted individuals such as friends or family, whoever they trust. And to my knowledge, this is the first study that engaged these individuals in the advanced care planning process during the COVID-19 pandemic through a secure online video conferencing platform. So the study used a single group pre-test and post-test design for this pilot, though the pre-COVID plan was for a randomized controlled trial. Participants were recruited from outpatient specialized geriatric clinics in Ontario, Canada between July 2020 and February 21. This was one of the most trying times in the pandemic as we still did not have COVID vaccines and the death rate was quite high for older adults dying with coronavirus. As such, I was able to successfully recruit about 21 dietes who attended the intervention together, and all the procedures were conducted over Microsoft Teams. There is a lack of clarity in terms of the essential elements of advanced care planning for those living with early stage dementia. So keeping in mind the barriers and existing evidence in the context of dementia in terms of advanced care planning, I identified 3 essential elements of the Voice Your Value intervention, and these included education to increase dementia knowledge, establishing the need for advanced care planning conversations, and personalized coaching to identify future care values and wishes of persons living with dementia around being in terminal and vegetative states. And these are the high-level results. The intervention demonstrated evidence of feasibility and acceptability in community dwelling older adults with dementia and their trusted individuals, as well as it led to significant improvement in outcomes of preliminary efficacy. What appears extremely important is taking a person-centered approach to ACP or advanced care planning, bearing in mind the unique characteristics and circumstances of those living with dementia. Based on the qualitative data that I collected, the presence of an interventionist with expertise in geriatrics was one of the critical reasons why Voice Your Value was considered acceptable. I did not only prepare tailored education, but I was also able to address questions that arose in the moment. Persons with dementia were keen to express their values and wishes for care through a personalized discussion, debunking the concern that these discussions could lead to psychological distress. COVID-19 pandemic provided me an opportunity to deliver the intervention virtually. Though there were challenges, the results of the study demonstrate that video conferencing is a viable tool to engage these individuals and that in advanced care planning conversations, and could be considered an option post-pandemic. In terms of future directions, I am currently planning a large-scale trial that will provide additional data to validate findings and inform the applicability and use of voice your values in clinical and other settings. I would like to compare the in-person to the virtual modes for the delivery of the intervention and train other clinicians as interventionists for the replication of this work. I am hoping to collect longitudinal data to determine if expressed values and wishes in the early stage of dementia gets translated into care received at the end of life. And I've also been engaging with persons with lived experiences in dementia and end-of-life care to disseminate these findings and identify opportunities to work together. The findings of the study they have been published in these journals, and I'll be happy to share them with you guys if needed. The conversation tool that I designed for delivering the intervention is also published on the SPA LTC website for use by healthcare providers in nursing home settings. So I can definitely share this link with you guys. Thank you so much.
Thank you so much, Shireen. I'm going to be stepping in. I'm Bianca Frogner, one of the members of the leadership of the award network. And just since Kezia is having some challenges in the background, I'll just be helping to get us to the end here. And last but definitely not least is Betsy White from Brown University. So if you want to go ahead and pull up those slides. And again, feel free to post questions and contacts in the chat to continue conversations. But I see great chat conversations taking place there. So please go ahead, Betsy, whenever you're ready.
Yeah, thanks. Really happy to present to this group. So I'm Betsy White. I'm an assistant professor at Brown. I'm a health services researcher focused on nursing homes. And I'm also a geriatric nurse practitioner, have spent a number of years working in long-term care. So I'm briefly just going to be telling you about a paper we have coming out next month, where we looked at differences in staff testing rates and likelihood of vaccination within facilities by different staff characteristics, but with a particular focus at looking at differences across work shifts. So if you know anything about what's been happening in the nursing homes, you know that COVID vaccines and testing have been really critical interventions for protecting nursing home residents and staff from COVID and for mitigating outbreaks. So we looked at shift as a structural factor affecting implementation. And we have a novel data source that we were able to leverage at Brown to use this through the Impact Collaboratory. We get electronic health record data from about 1,000 nursing homes that participate in a data sharing cooperative. And from a little bit more than a quarter of those participating facilities, we also receive staff data. So it's time card data, some demographic data, and then also staff level vaccination and testing data. So just briefly here, the specific outcome that we looked at for testing, we looked at testing rate, and it was test per 100 person days. And we spent a lot of time on this measure because testing is there are a lot of nuances to testing. So we really spent a lot of time making sure that this measure reflected days when the person was actually eligible to be tested, meaning that they were working and that they hadn't recently had COVID. And we looked at the time period from July 2020 to February 2021. So this was right after the rapid antigen tests were starting to be deployed in late summer 2020 through the end of that really terrible winter surge that happened just before the vaccines came out. And in our regression models, we controlled for a number of staff characteristics, and we also used facility and month fixed effects. And the reason for that is because there's significant temporal variation in testing, which I'll show you in just a minute. So we really wanted to compare staff within facilities within a similar time period. And then we also looked at vaccinations, and the outcome here was whether or not the employee had received at least one primary vaccine dose as of the end of March 2021. This was the end. So if you're familiar with the nursing homes, there was this big federal initiative to give all nursing homes in the country a series of vaccine clinics to vaccinate their staff and residents. So by the end of March, they had finished. So that was our time period for this. And in that analysis, we used facility fixed effects. So again, we're comparing staff within the same building. So I think the descriptive data so this is showing testing trends over time, and the descriptive data kind of tell the story here. So just really 2 key points from this graph. So the first is that the frequency of testing changed dramatically over the course of the study period. And there was really 2 reasons for that. One, as I mentioned, late summer 2020 was when the rapid antigen tests became available. So there was significantly increase in access to testing, which was really critical for the nursing homes. And then also this peak here, this is again that really terrible winter surge that happened right before the vaccines came out, which increased demand for testing. So really significant temporal variation, necessitating the need to incorporate time into our analysis. So the second key point to look at here is this is showing testing rates by shift. So the line on the top here is day shift. The next line, the yellow line, is evening shift. And then the bottom line here is night shift. And you can see across the study period, really significant differences where day shift is being tested significantly more frequently than night shift. And just to kind of quantify this for you, so if you're looking right here at the peak in December, this is saying that over 100-day period on average, so a little bit more than 3 months, that the day shift would receive about 12 more tests over that period than night shifts. So really significant differences here. And I'm not showing the adjusted output just in the interest of time, but in the adjusted models, we saw a very similar story to what you see in the descriptive data. And then when we look at vaccination, we see a similar story. And there's a lot of kind of interesting nuance by job type and other things that we could talk about here, but just to focus on shift here in the interest of time, we see a very similar story where we see significantly lower rates of vaccination on night shift versus day shift. And when you translate this to adjusted vaccination rates, it's a difference of about 67% vaccination rates on day shift compared to 50% vaccination rates on night shift. So really significant differences here. So just some key takeaways here. Shift is an important structural factor affecting implementation of these key public health initiatives in nursing homes, and it contributes to disparities across staff. So we actually observed lower testing rates among Black staff versus white staff, but we employed a series of interactions, and what we found is that when those disparities were primarily explained by shift, and there were a disproportionate representation of Black staff on the evening and the night shift. And so again, this is an important structural factor contributing to disparities. And when we're just talking a little bit about the why here, evening and night shift have fewer resources. The supervisors on those shifts already have multiple responsibilities, and adding on these additional organizational processes just adds to their already limited bandwidth. Evening and night shift also have less exposure to senior leadership, particularly the DONs and the medical directors, who have been really critical leaders for building trust, particularly around the vaccines. There have been some really nice studies that have looked at that outside of our group. And then finally, the workarounds to accommodate evening and night shift can be problematic and create hardship for staff. Making staff come in early, stay late, or come in on a day off create hardships, particularly for people who, have to get to a second job or, commute needs, or whatnot. So we thought this was kind of an interesting set of findings. Shift isn't something people had really thought about in the context of COVID. Happy to answer any questions, and thanks for letting me present.
Thank you so much, Betsy. That was great. And thank you really to all of our speakers for going through so many interesting studies and being so on time with so many of your presentations. You really packed this hour with so much great information. And this event was recorded and will be posted on the website, the new website that we have for the ORD network. So just posting that link there in the chat. And since we're nearly at the end of time, I don't think we really have time for additional questions, but I certainly encourage folks to continue to reach out to each other via email. And again, since the webinar will be posted online, we will certainly share it out through the network, so you may be hearing from others. And also just one last reminder is that we are doing these webinars every month, the first Wednesday of each month. So our next one will be February 1st at 9 a.m. Pacific time, 12 p.m. Eastern Standard Time. And we're really fortunate to have Channing Fabius from Johns Hopkins University as our guest speaker for that event. So thank you to everybody again. Would love to see a round of applause, virtually by all. And thank you for taking time today, and have a wonderful day, and talk to you all soon.